Good morning and welcome back to the Unfiltered Fix. I'm Megan Sharpe, and today we're discussing a topic that affects so many women, yet often leaves them feeling frustrated, confused, and searching for answers. PCOS and fertility. If you have ever felt like you're battling the hormone struggle by yourself, don't worry, you're not alone. And on a recent episode, I discussed my personal journey, but today I'm beyond excited to welcome back one of my favorite guests, Dr. Ruby Dang, to help us break it all down. And if you missed our previous episodes together, let me reintroduce you. Dr. Dang is not only a naturopathic doctor at Zen Dermatology and Regenerative Medicine, but she's also an expert in hormone balancing, medical weight loss, and helping individuals take back control of their health. She's empowering women to understand their bodies and find solutions that actually work. No more one size fits all, because we know that garbage doesn't work. Just real actionable strategies. Today, we're going beyond the diagnosis to talk about what PCOS really means, how it affects fertility, and what you can do right now to optimize your hormone health, whether you're trying to conceive or simply just want to feel better in your own skin. And I know that you'll find this episode insightful. Good morning, Dr. Ruby. Thank you again so much for joining us. And it's always such a pleasure to have you on the show.
What an introduction, Megan. Thank you. I'm so excited to talk about this topic because it's something that I feel like is starting to get a little bit more awareness around, but there's still so many questions left unanswered. Let's dive in and debunking PCOS and fertility.
Yes. Hormones are one of those topics that we could seriously spend hours on because it affects everything, as you know. And obviously, we have to break this down into chunks. But before we start, I want to start with you. What got you into specializing in hormones in the first place, especially for women of childbearing years? Was there like a specific moment or experience that really sparked your passion for this field?
You know what? I mean, everyone can have a personal story, and I'll dive into my personal story in a moment, but I feel like I was the generation that got slapped birth control for every little thing. Heavy periods, birth control, lack of period, birth control, acne, birth control. And so birth control was just rampant in just the population. And so many women started, being an advocate for themselves, feeling like they just didn't want to be on it anymore. They didn't like the symptoms. They didn't like the mood changes. And now we are dealing with all of the consequences of the population that's been on birth control and how it leads to higher instances of hypothyroidism and potentially Hashimoto's. It can lead to concerns with fertility. It can lead to a lot of PCOS. But for me, I was someone that also grew up with just irregular cycles, and I didn't want to go down the path of birth control. And it was actually in medical school when I got my first series of hormone testing done that I found out myself that I had PCOS. I didn't have the classic symptoms, and I was someone who didn't fit the classic bill, of oftentimes conventional providers like you have to have a certain BMI to even consider testing, or lack of irregular periods when I was having regular cycles. But it's something that at least it was caught early on that I was able to get it under control, because it's something that women aren't testing until later on in life when they're having trouble with conception. And it's not something that changes overnight. It takes months, if not years, to really help to reverse a lot of the symptoms of PCOS.
That all sounds far too familiar. Definitely all of that was part of my past as well. And gosh, if I knew then what I know now, I feel like things would have been so different. So I'm so excited to have you on here to talk to our listeners about this topic. So I think many of our listeners have probably heard about PCOS. I'm sure they've heard that term before, but they might not fully understand its implications. This is something that affects upward of 10% of women, which is actually quite a large number if you ask me. Can you explain to our listeners what polycystic ovarian syndrome is?
Absolutely. PCOS is essentially a little bit of anatomy. So, we have our ovaries, and every single month we have eggs that mature and we release that egg, and that's our menstrual cycle. But what happens in PCOS and why we have multiple cysts on our ovaries is due to hormones. We tend to create a multiple amounts of different follicles that essentially don't mature and we don't release an egg. So when we do an ultrasound, we see these tiny little cysts, and they call them a string of pearls that are wrapped around our ovaries. ovaries because they're essentially immature follicles. And the reasons that we have these immature follicles is because of different hormones impacting the health of our ovaries. So I'll break down, there's actually 4 different types of PCOS. There's the subsets, all tend to have various origins. The most common one is having higher amounts of androgens being our male hormones, testosterone, DHT. So women, we have that, and that's essential for us, but sometimes we overproduce that. And that overproduction is a huge reason of why we have that miniaturization of our follicles on our ovaries. And then we have an inflammation or an inflammatory type of PCOS. That can come from just having a high inflammatory load in terms of our diet, in terms of our gut health, in terms of our environmental factors too. Also a cause of post-pill PCOS, which is another one, where when we're taking birth control, all of our hormones are suppressed, including our androgens. And when we get off of birth control, we have this rapid surge of our hormones, because if you think about it, there's been this outside influence that's been keeping our hormones at bay. And then when we remove that influence, our hormones suddenly are awake again, and they kind of tend to rev up, especially in that first 3 to 6 months post-pill. So that can lead to having a higher amount of androgen levels too. And then lastly is one of the more common types, which is an insulin-resistant type of PCOS. And so having a dysregulated insulin and blood sugar levels can also affect androgens. All of these different types can have different symptomologies and different appearances in the way that the PCOS presents. Hence why I think it's so important to also test to figure out which one does each individual have too.
And here I am still learning. I knew that there were different reasons for PCOS and causes, but I actually didn't know that there were 4 different categories. When somebody is diagnosed from their OB-GYN, is that something that they typically categorize for them, or do they just lump it all into a PCOS diagnosis?
Generally, from what I've seen, is they tend to lump it into just the PCOS diagnosis. So there's something called the Rotterdam criteria, and that's how you actually diagnose PCOS. The classic definitions, you have to have 2 of the following symptoms. So one of them is having either irregular ovulation, irregular menstrual cycles, or a lack of ovulation. So those type of women, you can actually assess to see if they're ovulating through LH. You can also kind of time it through, cervical mucus, menstrual cycles, with understanding their menstrual cycle if they or have a lack of one. That's one criteria. One is actually elevated androgen levels. So it can either be through testing, so you can test the testosterone as well as the DHT, or they can have the symptoms of high androgen. So that can be cystic acne, it can be hair loss, it can be oily skin, oily scalp. And then the last one is through having the actual polycystic, that symptomology on ultrasound. So you can see the ovaries and see if they have multiple cysts on them. So they have to have 2 of the following 3 criteria. So conventionally, if they have 2 of the 3, then they usually get the diagnosis of PCOS. It's through further testing and investigation where we can actually be able to pinpoint a little bit better what subset of PCOS do they actually have.
Interesting. Thank you for sharing. So that's actually a good segue into my next question for you is, how does PCOS influence a woman's ability to conceive? Because I hear so often friends of mine or just women in general have said that their doctor diagnosed them with PCOS and that they might not be able to conceive. And I feel like, that's doing them a huge disservice. While we do know that that's probably some cases, that's not true for everyone. So can you break down how this affects their ability to conceive?
Absolutely. So to go back to it, if a woman isn't actually releasing an egg, no implantation can occur. And so the body's trying to release the egg. It's creating the follicles, but the follicles are not maturing. If the woman is not ovulating, and despite, having, let's say, a regular 28 to 30 day cycle, because that is possible, without the release of an egg, they will not be able to get pregnant. And so that's why starting the journey and understanding if PCOS is something that a woman is faced with is so important, because it can take months, if not 1 to 2 years, to really focus on getting the egg to mature and release. And so that's why it is challenging for those with PCOS to get pregnant. And so sometimes they release an egg 1 every 3 to 4 cycles, and you don't know, you can't actually be able to be like, okay, this is the month I'm releasing an egg, because it's so, variable. So that's why most of the women have that trouble. And so in addition to fertility, it is important to also assess the male and the partner's health too, because that's starting to become a bigger role when it comes to fertility, because we have so many endogenous hormone in our environment. We have so many endocrine disruptors too. So I think it's a journey of both partners to go down together to ensure that their egg quality and their sperm quality are in optimal health too.
Absolutely. And I think it also just opens up that open line of communication. And I think when people are going through this, sometimes it can be a really challenging piece of their life. But I also think that it can be something that will strengthen your relationship moving forward when you guys are going through this journey together and not just keeping quiet about it.
Exactly. And I always tell, any of my patients who are even having the thought process of conception, you have to start even thinking about conception a bare minimum of 3 months prior, because anything you do now will affect the health of your egg 3 months from now. And, I was actually watching a video recently of this male that was saying, women who are pregnant, they have 9 months of nurturing the baby, preparing for the baby. And why do men just get away with not having to change anything? The health of the mitochondria of the egg and the sperm should begin 9 months prior to even conception too, with, optimizing diet, reducing toxins in the environment, taking the correct supplementation, optimizing hormones too. So I think, going on this journey with a partner together will feel really empowering to know that, we both are here doing this together to affect the future generations and the future children to come.
Yes. Oh my gosh, that is such a good point. We are not the only ones that should bear the child, like quite literally. It is definitely a partnership. For women that are experiencing irregular periods or unexpected weight gain, PCOS might be a concern. But what are the hallmark symptoms that they should be aware of, and what steps should they take to get an accurate diagnosis?
This is a great question, because nowadays there's a lot of different, hormonal related concerns that are coming up, and people are having a harder time trying to differentiate what's endometriosis versus fibroids versus PCOS. So I'd say the more classic symptoms that present with PCOS is, first and foremost, just a regular menstrual cycle. Maybe some months it's 25 days, some months it's 35 days. It's a little bit harder to pinpoint. Hirsutism, so having hair growth, unwanted hair growth. So women tend to get a little bit of stubble on the upper lip, some potentially on the chin, the neck. So places where men tend to have more hair growth. Also thinning hair. So a lot of women tend to have more of a widened part line, more receding hairline too. It can lead to oily skin. So they wash their face 2 hours later. It feels like, they got some grease on their skin. Like they just feel like no matter what they do, they can't control the oil. Cystic acne, that's also all throughout the cycle. So usually it can increase during ovulation, because that's generally when androgens are a little bit higher, but also just harder to pinpoint type of acne, not that type of acne that comes on the week before the menstrual cycle. And then also weight gain. So it generally tends to be around the abdomen too. And a lot of these women are, they're in the gym every day, they're running, they're weightlifting, they're eating clean, and they're like, I just cannot get the weight to budge. That's also a common symptom of PCOS. And then the difficulty conceiving. So for those who haven't gotten their hormones tested and they're trying to conceive, they're having a hard time, that's a common symptom as well.
So something came up as you were talking, and correct me if I'm wrong, fibroids can actually cause some of these symptoms as well, correct?
Some of them. So fibroids generally are really, really heavy menstrual cycles. A lot of pain and cramping while a woman is bleeding too. Fibroids can lead to heavy clots. Just think about, like, women are generally fine, and then they tend to get that significant PMS either a couple days to a week before their menstrual cycle, and then just having really heavy bleeding. And then the heavy bleeding can go ahead and trigger low iron levels, which can also trigger hair loss. So that hair loss piece might be similar too. But for those who are having just heavy, painful periods, I would evaluate fibroids for that.
Okay. Yeah, that makes sense. So when I was going through my symptoms, when I still had a cycle, I had very, very light cycles, but excruciating cramps that came along with them. So I think that was probably one of the biggest differences between, like, say, my cycles versus my mom's cycles, because she had the fibroids and I had PCOS.
Yeah, with PCOS, there can be some heavy cramping too, and that's very common. It's not always classic, but it can definitely present in a lot of women.
Dr. Ruby, as you know, I recently started microdosing Tirzepatide, and so I've been doing a little bit more research on it, and I came across quite a few studies that indicated that GLP-1s, such as Semaglutide, Tirzepatide, have actually shown to improve several symptoms of PCOS. Mm-hmm. I know it can help with weight loss, obviously, and improve insulin resistance, and that's what we hear most about these GLP-1s, but it's been reported to also help regulate menstrual cycles and induce ovulation. What are your thoughts about that? And would that be more of a microdose versus used in higher doses?
So I think I didn't answer one of your previous questions, so I'm going to loop that into this question too of how do you evaluate for the different types of PCOS too. So the Tirzepatide and GLP-1s are great for the insulin-resistant type of PCOS. The way that we can identify if someone is insulin resistant is we can actually assess their insulin levels. So this is something that a person can go to the nearest, lab facility, get their insulin levels done with a lab script from their doctor, be fasting for it, and you want to get it in the morning, so not having consumed anything. And something that's unique about insulin resistance is you can actually assess something called HOMA-IR. And that lets us know is a person, moderately insulin resistant, low insulin resistant, or high insulin resistant. So there's usually a reference range, and it's anywhere from, I can't remember the lowest number, I'm going to say like 0 up to 18.4 is classified as normal. But what's technically insulin resistant is greater than 10. So you'd like to be less than 10. Ideally, if you can be under 5, that's better insulin control too. You can also assess for hemoglobin A1C and your fasting blood sugar. So a lot of the women who have any type of insulin resistant PCOS, that tends to push more of their androgen pathway. Those are really good candidates for going on a GLP-1 or going on other alternatives to GLP-1 too that helps to support their blood sugar, such as berberine, alpha lipoic acid, and chromium. And so with those women, we like to check their insulin levels, hemoglobin A1C, blood sugar beforehand, encourage a healthy diet, making sure they're eating adequate amount of protein, reducing blood sugar spikes throughout the day. I love, giving them a continuous glucose monitor too to get a better understanding of what's happening with their blood sugar levels, and then potentially discussing are they a good candidate for it, because with controlling the insulin levels and controlling the blood sugar levels too, the body is not in so much of a state of kind of like fight or flight, because when we have spikes in our blood sugar, it's a stressor to the body too, and it can cause certain androgens to surge. So when that's controlled better, that's why we have a better control of fertility and our hormones too. And so there are better chances of conception as well.
I'm glad you brought up the continuous glucose monitor, because it's something that I just recently did, and I found it so insightful just to kind of track how my blood sugars are peaking and dropping and, what caused them. And I kind of geeked out on a little bit. I only wore it for 7 days, but it was really fascinating to me. And so I love that you brought that up and recommend it for your patients too.
I think it should be part of every annual exam because it gives us so much valuable information. I'm sure as you saw too of like, oh, okay, if I have a protein dense meal, my blood sugar is flatlined for a while. Or if you have some pasta, it can spike up and then dip down and go too low too. So we can just learn and see, how does our blood sugar affect our mood? How does it affect our energy? How does it affect our sleep too? Because I think we were chatting one time and you were saying your blood sugar dropped either in the middle of the night and you were hungry, or throughout the day and you were a little bit hungry too. And that has a significant role when it comes to our productivity as well. So there's so much that we can learn from looking at our blood sugar levels continuously.
Yeah, I was noticing that as they dropped, I would actually wake up in the middle of the night very jittery, and I would even start sweating, which I thought was related to my hormones, which, part of it might have been, but I really did notice that it got so low that I think it was really more the contributing factor was my blood sugars.
Mm-hmm. Yeah.
All right, so let's talk about fertility now. So navigating fertility treatments can be overwhelming and extremely expensive. I have many friends that have actually gone through this. It's something that not everybody can afford, obviously. Can you walk us through the most effective treatment options available for women with PCOS that are aiming to start a family or those struggling with fertility issues?
I'm going to give a little disclaimer first here and say that, I'm just going to give a little bit of information, but if anyone does have PCOS, wants to, test their hormones, is curious about fertility, definitely work with a doctor to get more of a tailored and individualized plan first and foremost. But I'll go through some of the more common treatment recommendations that are conventionally as well as more integratively used. So for those who, let's say, it kind of depends on the timeline. So I'm going to start with a timeline of how soon a woman wants to conceive, whether it's 1 year, 2 year, 5 years, but let's start with the 1 to 2 year mark. It also depends on the age. So I would always start with, if someone's trying to conceive and they have PCOS, always work with the fertility specialist, because it will take a lot of pain and heartache and time out of the equation, because they usually will go ahead and prescribe one of the ovulation inducing medications. So it's either the letrozole or clomiphene. And so what these do is they help with supporting the production of ovulation, because as we know with PCOS, there is that anovulation. So a lot of women women just don't ovulate because they're not releasing an egg. With these medications, you have to time it at a specific part of your menstrual cycle to induce the ovulation. Sometimes women have to also have low progesterone in the mix too. A little side note, I often see elevated androgens and low progesterone as an inverse relationship. So that's kind of your classic, infertility picture right there. A lot of women are taking one of these medications, potentially some progesterone, and they do that for a couple cycles. Statistics show that 70 to 80% of women do conceive following various medications within 6 cycles. But that being said, a lot of these medications have just they rev up your hormones too. So knowing that it can affect mental and emotional health is important going into it. Then looking at things from more of the insulin resistant level, that's something that some women can go on one of the GLP-1s for. They can go on the blood sugar supportive herbs for as well. And for more of that insulin type of PCOS, we really focus on blood sugar management through diet, through lifestyle, through exercise, and just supporting the optimal health there. And then for those with high androgens, I'm going to kind of go back to first, how do we test it? With testing, you can look at the DHT, the free and total testosterone too, to see if those are playing a role. I love to test hormones through something called the Dutch test because I like to see if there's a stress component too. Cortisol is one of the biggest drivers of revving up our hormones too. And if our body's in a state of that fight or flight, it's not going to be able to conceive. The body needs to be in a state where it is safe enough to conceive too. So making sure cortisol is not playing a role is important. But for those with higher androgens, I will say it is a little bit more challenging to lower them naturally in a short period of time. It usually takes these hormones about 6 months to a year to lower. Some recommendations that I love to give my women with more of the higher androgen PCOS are things such as saw palmetto, pumpkin seed, consuming spearmint tea, something called nettles. All of these help with reducing those androgen levels. And then for those who have more of that inflammatory type of PCOS too, that's really where diet comes into, and diet can help to support looking at digestive health too, looking at food sensitivities, and optimizing those are just good strategies to help with reducing the inflammation.
Something you mentioned a minute ago were high androgens, low progesterone. Now, I know that sometimes conceiving isn't necessarily the issue for some, but carrying full term is a concern. And I know one of my friends who also had a diagnosis of PCOS, she was having a hard time actually carrying the baby. And so one of the things that her physician did was recommend doing progesterone injections, I believe is the method that they used. Is that something that you see pretty frequently?
Yeah, so some people have no trouble with actually conceiving, but then they have the trouble, like you said, with carrying. And so they get these repetitive miscarriages. When I hear that, I usually think of the progesterone is not rising in the way that it should. And so they're releasing the egg, the egg and the sperm implantation is possible. And usually what's happening is the body sometimes is in a state of stress too, and that can deplete progesterone. So there's different forms of taking progesterone. There's an oral progesterone that people can take, and there's actually a vaginal suppository progesterone, which a lot of fertility specialists are moving towards utilizing that because it's giving progesterone locally to the uterus, and that can help with maintaining the pregnancy. And so this is something that has to be done with a specialist, and it's not something that a lot of just PCP will do. It's more so OBGYN and fertility specialists, because they have to be able to monitor the progesterone levels and also kind of taper down at a certain point. It's usually done within the first trimester of the pregnancy. Leading up to it, there are ways you can help to optimize your progesterone too. So there's foods that women can eat, and two of my favorite foods are actually seeds. So sesame and sunflower seeds, 1 tablespoon of both of those actually help with boosting progesterone levels. So on kind of the fertility journey, I always recommend women to seed cycle. And then there's also some herbs that women can take as well that help to boost progesterone. And Vitex, otherwise known as chaste tree berry, is one of the most common ones. And there's mixed, reviews of taking it during pregnancy. So same thing, I recommend to always check in with a fertility specialist about it. But yeah, progesterone is something that is essential with the maintenance of pregnancy.
And then beyond the medical treatments, you had just mentioned that diet is a big one. Are there certain strategies for diet and exercise that you would recommend?
Absolutely. So for every woman as well who's starting to think about conception, I put them on the fertility diet. 2 areas of health that are essential is obviously diet and exercise. A lot of women are under eating, over exercising, intermittent fasting, having their cup of coffee that gets them to lunch. And so their body's just stressed. So we tried to back it down. I try to get them reduction of coffee, try to swap out with some matcha, get protein, at least 30 grams first thing in the morning, ideally within 1 to 2 hours of waking. That helps helps with regulating blood sugar as well as hormone levels. So our hormones don't surge throughout the day too. And then with the fertility diet, we want to focus on a lot of omega-3s. So that can come from different seeds, that can come from nuts, that can come from kind of following more of a Mediterranean diet, olive oil, salmon if they like it, the fatty fish, lean meats, a lot of antioxidant-rich fruits and vegetables. I like to say the more colors, the better on a plate, just because we need all of those nutrients to help to support the quality of the egg. So just food becomes a big role when it comes to fertility.
And I know that this can actually be a very challenging area to really shift your mindset from a specific diet to actually incorporating this as a lifestyle change. And everything that you just mentioned is ideal and phenomenal to support your overall health and wellness after you conceive and carry the baby full term. Like, you need that stuff for when you're nursing and just continuing on with that lifestyle. So I really don't want people to think of it just as the fertility diet, but making those lifestyle changes before they even try to conceive and then maintaining that moving forward.
Absolutely, because who wouldn't want to nourish themselves and their babies with the highest quality food?
Definitely. Well, dealing with PCOS and fertility challenges can take an emotional toll. So I want to take a minute and talk about the intersect between this and mental health and what resources and strategies women can utilize to support their well-being.
This is something that's not talked about enough, Megan. So thank you for bringing this up, because I have worked with quite a few women who've struggled with PCOS and struggled with infertility. And it does play a significant role in their mental health, especially when everyone's posting pregnancy announcements, baby showers, and all of these things everywhere. And some people feel like, why me? Why am I unable to? Why is it not my turn yet? I think working with a counselor and a therapist is so important along this journey. There's a lot of different fertility related groups that women can join too. There's different reproductive centers, fertility centers that have these support groups that women can join. And I think, other things that have helped some of my patients too with focusing on the mental and emotional aspect is something called Reiki. So it's energy healing. And what it does is it can help with reducing the burden that we feel on our bodies and just kind of reducing the energetics around the situation of what's happening and get us back in touch with our own selves and our own health. And then the last thing that I actually recommend a lot of women to do to improve chances of fertility and help with stress and mental and emotional health is actually acupuncture. So did you know that acupuncture can improve ovulation and it improves circulation to the pelvic region? And so it's something that is so beneficial for so many areas of health when it comes to fertility and the mental and emotional aspects of around it too.
Yeah. And, I know that this is such a personal journey and everybody handles things differently. Somebody very close to me struggled with infertility. And so I do get a little bit choked up because I know the mental toll that it took on her. And like you said, when everybody else around you is posting videos and pictures and talking about how beautiful their new baby is, and I know how much it hurt her. And I think one of the things that made it even more difficult was the fact that she felt like she had nobody she could talk to about it. And so I think surrounding yourself with people that understand what you're going through, whether they've experienced it themselves or they can just be there as a support system for you, is so very important.
I couldn't agree more.
Looking beyond fertility, what long-term health considerations should women with PCOS be mindful of, and how can they proactively manage these potential risks?
This is great too, because we often think about PCOS in the moment and not the long-term health implications too. As we've kind of heard today, PCOS, there's a big insulin metabolic health component to it too. So if PCOS is left untreated, it can, lead to some forms of type 2 diabetes. It can lead to cardiovascular disease. It can lead to just chronic inflammation, which leads to a whole host of symptoms. It can lead to just cortisol dysregulation. It can potentially lead to something called endometrial hyperplasia. So what that means is we have just kind of a buildup of estrogen in the body too, especially if we have those lower amounts of progesterone. It's so important to get this diagnosed and under control because of its long-term effects beyond fertility too.
Thank you so much, Dr. Ruby, for sharing your knowledge and insight today. Hormones, especially when it comes to PCOS and fertility, can feel overwhelming and frustrating, but conversations like this remind us that there are in fact solutions and that taking control of our health is absolutely possible. So if you've been nodding along or feeling like you finally have a better understanding of what's going on with your body, I encourage you to take the next step. Whether it's booking a consultation with Dr. Ruby at Zen Dermatology and Regenerative Medicine or somebody else that specializes in this area, getting your hormone levels checked or making small lifestyle changes is what's going to be key. And remember, you are your biggest advocate. And if you found this episode helpful, please don't keep it to yourself. Share it with your girlfriends, your sisters, or anyone who might need to hear this. And of course, make sure to subscribe to the Unfiltered Fix so you never miss an episode. You can also follow me on Apple Podcasts, Spotify, and YouTube for even more insights and real talk about health, wellness, and confidence. Thank you so much for tuning in today. And until next time, I hope you have a wonderful day.